Hello and welcome to today's OR Today webinar. Our presentation for you today features Victor Lange, Director of Quality, Risk Management, and Infection Prevention at AHMC-Greater El Monte. OR Today would like to thank our sponsor, Encompass Group. Encompass is one of the world's leading manufacturers and marketers of reusable textiles, professional apparel, and disposable and single-use medical products. Encompass believes that every patient, resident, caregiver, and family member should feel safe and comfortable in today's healthcare environment. The way Encompass enhances the healthcare experience is by developing innovative products that are reliably delivered and cost-effective for all providers. Markets include acute care, long-term or senior care, retail healthcare apparel, hospitality, and government operations. For more information, please visit encompassgroup.com. We are excited to announce that OR Today magazine is celebrating its 20th anniversary in 2021. For the past 2 decades, OR Today has provided perioperative and SPD professionals with up-to-date news and information about their profession. We'd like to offer today's attendees a complimentary subscription to OR Today magazine. To get your free subscription to our magazine, please visit ortoday.com/subscribe. Today's webinar is eligible for 1 continuing education hour by the State of California Board of Registered Nursing. You can obtain your certificate by completing today's post-webinar survey. The survey will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 CE hour, and you will be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, please contact us at webinar@mdpublishing.com. As I mentioned earlier, Victor Lange is our presenter today. Victor possesses legal and regulatory standard expertise and conducts ongoing surveillance, documentation, and investigation of hospital-acquired infections. He has implemented numerous clinical education programs, providing staff with essential knowledge and skills on infection prevention, ultimately improving both healthcare worker and patient safety. Victor, you may begin whenever you are ready.
Thank you very much for the very nice introduction, and I am an honor. It's an honor to be part of this presentation, to share some of my experiences as well as some of the outcomes of studies that I've conducted in this arena. Again, thank you very much. My background, again, is an epidemiologist, a healthcare epidemiologist. I also have a legal background, so I've been keen to a lot of the regulatory or the regulations surrounding the industry, especially as it pertains to various CDC recommendations. Also, in terms of how the OR environment may be implicated in many cases that can be litigated further on in the future. So I kind of bring both the epidemiologic standpoint, the clinical research standpoint, as well as the legal standpoint with what I do on a daily basis. In this particular case, again, the study or this particular presentation, we're focused on our learning objectives, which are understanding the cross-contamination risk factors associated with the operating room, or in this particular case, forced air warming product use, so FAW product use. We've studied so many different devices used in the operating room, and again, it was time to look at the air warming devices themselves, because we've looked at all of the other technologies implemented in OR cases. But again, as I mentioned before, the patient warming itself to maintain normal thermia, the risks of the air itself circulating around the patient, places the patient at risk, as well as the environment at risk of cross-contamination. So we'll describe a data-based correlation through various studies that we have performed regarding the forced air warming device components, airborne contamination in the OR itself. And then also it's important that the infection preventionists at the hospitals be aware of this internal facility risk issue by conducting risk assessments, by seeing exactly what some of the risk factors may be, including the forced air warming in the OR suite. So the content of this particular presentation are to discuss the benefits of patient warming, to discuss also forced air infection risks with the forced air products, also to discuss how we conducted these studies, the methods. We look at the findings of the studies and discuss conclusions, as well as any questions and answers that the audience may have from this particular presentation. So to begin, as we know, the patient warming obviously is vital in maintaining perioperative normothermia, thereby reducing temperature-related complications, improving postoperative results, and shortening the patient's length of stays. So again, normothermia in itself, the goal is to improve outcomes. And what we see here is that while we're improving outcomes, we also may place patients at risk, especially if the device is not able to be disinfected appropriately after use in the patient. There have been a number of published studies that point towards surface component contamination, as well as tissue and the air risk connection. So again, we've seen studies and correlations, and also our studies do demonstrate that forced air warming devices do and can introduce bacteria into the OR environments, thereby increasing our risks of contamination to the OR suite, as well as leading to a risk of potential surgical site infection in our patients. And to understand this, we need to look at just the overall environment in which these patients are operated on. We need to look at the airflow in the room as well. And we need to also understand that we have such a massive number of skin cells that are continually being shed from the body surface, in this case the patient's body, even the healthcare worker's body. And many of these skin cells may carry microorganisms, including Staphylococcus aureus, methicillin-resistant Staph aureus, just to name a few. And when they're present in the OR, these types of cells and these types of microorganisms may lead to infection risk. And it's just amazing because as many as 10 million of these normal skin cells with pathogens attached to them can be shed in a 24-hour period, for example. So any surgical procedure that's performed, if we're introducing these types of skin cells through either the air in the OR or through a forced air warming device, we see a significant risk posed to the patient. So we've conducted studies with points to surface component contamination, as well as the tissue to air connection. And again, we need to look at the airflow, because the airflow, when it's moving around a patient, obviously creates risk. So in this particular illustration, we see hot airflow from a forced air warming device, which could disrupt laminar airflow in the operating room. Because again, this air is circulating around the patient. We see the disruption of the laminar airflow bouncing back because of the air currents produced by a forced air warmer device. So again, all of these things correlate with risk factors being increased for the patients, increased also in terms of contamination risks to the personnel. So study objectives, when we looked at the study, we looked at all these various factors. And these factors were to look at how we can conduct research where we can measure any type of forced air warming device and any bacteria correlation data, which will help us better understand the use of these forced air warmers, the risks that they may raise, and we look at possibly creating new infection prevention or infection control protocols to mitigate or diminish any type of risk of healthcare-associated infection. because again, it's the risk factors that we bring into the OR that we need to look at eradicating. It's also important to address any type of guideline established by any type of professional society, regulatory body, any agency that may help us understand how we can further prevent and reduce the incidence of surgical site infections, any other type of healthcare-associated infection, and also any other adverse surgical patient event. You know, we're so focused on timeouts, we're so focused on looking at the different antibiotic infusion rates, you know, prior to incision. We're looking at all of the factors in the OR in terms of skin prep. We're looking at the disinfection of the environment, but something as simple as a forced air warming device that may be brought into the OR that has been already cleaned or disinfected may actually place patients at greater risk. So we're bringing a risk into the OR when the risk was eliminated initially with the proper cleaning and disinfection of the OR suite. So to conduct the study, we looked at and collected air samples. And the air samples are collected through a device. It's a normal microbiological air count using a one-stage viable impactor. It's an air sampling device. It has a flow rate of approximately 100 liters per minute. We collect this air for a period of 10 minutes minimum, and we then disinfect the device, and the device itself prior to disinfection has content removed, which is then allowed to incubate to see what grows. And so we look at the colonies from the dishes, we conduct gram stains, we look at any positive or negative bacteria under microscopy, and we look at the various counts and express them as CFUs, or colony forming units. And so these particular samples were not only obtained from the air itself, but we also swabbed the internal hose as well as the proximal and distal hose ends of the forced air warming device, because again, even these connection points had potential air contaminants, in this case skin cells or bacteria. So during collection of the environmental specimens as well as the air specimens, we sampled and sterile bagged. We plated and incubated under sterile procedures. And so this all helps us understand what types of cells are present and what types of risk factors are present in the environment as well as in the forced air warming device as well. So with our findings, so of the 320 samples collected, 78 of them, which is 24.4%, had higher than maximum acceptable colony forming unit concentrations of pathogens. So in this case, each of these specimens grew out at least 30,000 colony forming units per each collection. So you know, that's quite high. So 78 had higher than maximum acceptable. 136, which is 42.5%, had a higher than minimum acceptable CFU pathogen level of 10,000 colony forming units. So again, that was kind of the low end of the threshold, and again, 136 of the specimens were higher than the low threshold. We also looked at equipment samples, which was 119 of the equipment samples and 17 of the air samples at 5.3% of the total collected samples. So it's also important to understand the contamination limits. Contamination limits depend on the type of environment. So we see class 1, class 2, class 3 types of air contamination limits, and this is something that we've seen established by professional organizations, in this case the World Health Organization. And you know, the whole premise behind this is that there should be some level of acceptable, there's virtually no way of sterilizing the entire OR suite. You can sterilize surfaces, disinfect surfaces, but to have zero pathogens or zero cells floating throughout the air is virtually impossible. So that's where they established these particular thresholds, and these are the thresholds that we've followed as an industry over time. So again, if you look at the class 1, this is like your ortho operating room, cardiac operating room, transplant, bone marrow burn unit, highest risk patient population as well as settings in the hospital. And again, we look at about 10 CFUs as being like a limit. Anything above, we take into account depending on the types of surgeries we perform. The class 2 surgeries or patient departments in the hospital, the general operating room, the emergency department, the pre-op area, any OR corridors, the PICU, the surgical intensive care unit. We look at acute patient rooms. Again, the class 2 escalates the number of limitations on the number of CFUs of pathogens in those environments. And then class 3 has the highest rate, and again, that's outside the operating rooms. This is, your normal patient rooms, supply areas, radiology exam rooms, kitchen, laundry. And again, numbers can increase because, again, the risk factors in those areas are not as intense. So from this particular study, we can see here this particular chart, and this is figure 1, which is the cultured results based on 1,000 CFUs. So we see the maximum level of CFUs here being at 30,000 colony forming units. We see that being the maximum level. We see several that are above the maximum level, and then we see several that are above the minimum level, or actually even below the minimum level in terms of air sampling, looking at both the distal hose end, the proximal hose end, as well as the internal hose surface. So again, we look at all of the various components of this particular device, as well as the OR, and we look at the various factors that are involved in these particular study findings. So what we saw here is that the forced air warming device, the component contamination may be a heightened risk for the OR, for the patient. Again, we look at the number of skin cells shed. We look at the overall airflow disruption in the OR. If it's a laminar flow disruption, that in itself impedes and increases the risk factors because we're disturbing the air balances that are so important to that environment. We look at cross-contamination. Cross-contamination is such a huge risk as well. Cross-contamination from the forced air warming device can further cross-contaminate into the OR, and into the OR what we see is instruments being contaminated through air, as well as healthcare personnel and ultimately the patient. The patient can actually have an increased risk of surgical site infection as well. So there are air-free warming methods that may exist, which we always urge to look at the least invasive, the least risky device to use in our patients. Because again, if we have a device that actually can potentially contaminate the air and the patient, this is quite a significant issue. There has been a high pathogen contamination in all of the forced air warmer temperature components, resulting again to an increased risk of cross-contamination and infection in our patients. So there are clinical intervention studies that have proven with beneficial outcomes. And again, there are numerous studies that have been published that are looking at the environment, implant infections, what could potentially lead to an implant infection. And we're seeing that the air itself may potentially be the seeding factor for some of these deeper, higher risk, costly outcomes or costly infections in our vulnerable patient population. Because again, these patients are so vulnerable to anything that potentially can contaminate them. I mean, we look at everything from the air warmer itself to even the smoke plume that's generated through cautery. There's even exposure risk from the smoke itself. It can contain viral fragments, bacterial fragments, carcinogenic agents, and so if you increase the risk from every device that's used in the patient, then the risk and the odds of infection are increased significantly. And so nursing staff in the operating rooms, as well as infection preventionists at the facilities, would really benefit from further consideration of looking at everything they have in the operating room, looking at the forced air warmer. What type of air warmer are they using? Is it possible to disinfect every surface? Because if you look at all the different surfaces that these air warmers have, for example, hoses, for example, hose connections, how can you adequately say that that item has been disinfected? Have you really disinfected the inner surfaces of these air devices as well? Because chances are that most likely you have not. Usually it's just the surface that's disinfected, and most attention is placed on the surface itself. So study results from this particular study that I'm presenting of the 320 samples collected in the various ORs. These studies were presented at the APIC National Conference in 2019, as well as with an AGIC abstract publication, and also at AORN 2020 with a virtual poster publication. And so we're in the process of conducting a follow-up study to see what other types of devices and what other types of procedures may be a risk factor, but also, are there other devices that may decrease patient infection risk, but also increase the management of normothermia without placing the patient at risk of potential airborne contamination or airborne contamination risks. So again, it's so important to look at the overall picture and the overall scenario that we deal with, because there's so much that people don't understand, especially the healthcare workers that rely on best practices. They rely on the tools and techniques that are best practice based on regulatory and professional societies. But we also need to look at just what's in front of us. What can we do to immediately change an issue? What can we do to change a process to help improve outcomes with the simplest methods possible? That's why we looked at the forced air warming device, and we looked at the risks inherent that no one has known for all of these years. So in terms of some of the discussions, we also look at air quality, monitoring of air quality, as well as the HEPA filtration in the OR. Can a HEPA filter be used to help decrease, like an extra HEPA filtration, a secondary HEPA filtration, or may it not adequately prevent microorganism cross-contamination and transmission? Because again, we're seeing that based on this particular study itself, with just a select group of air warming devices, the study found high volumes of various staph species, Staphylococcus epidermidis. We also saw increased volumes of Staphylococcus aureus, Staph pyogenes, Cornicobacterium species, Propionibacterium species. These are all normal skin contaminants or pathogens that are found in the patient's skin. But again, our patients are very vulnerable, especially patients that are hospitalized, critical patients. And then you look at our highest risk patients, your transplant patients, your oncology patients. Those patients virtually have no immunity for any type of pathogen exposure. And then now we compound that with COVID-19. And COVID-19 in itself has added so many risks to our patients that we need to look at ways that can help minimize even further the infection risks. And with COVID-19 added to the mix, now we truly have a call to action to look at everything we use in the hospital, in the operating room, to help minimize or further minimize infection. And then from a litigation standpoint, unfortunately, our society is just far more litigious day after day. COVID-19 is just one of those new things that, unfortunately, the new ambulance chaser, attorneys will be now chasing all COVID-19 cases that occur, whether or not there's proof or not. The hospitals have been impacted significantly, and that's why we need to really address our concerns. We need to address what we have in front of us and help minimize risks to our patients. As you also know, surgical site infection litigation has gone up substantially. We see cases in the hundreds of thousands, $400,000 on average for a economic burden with a joint replacement infection. We see them in the millions. So anything we can do to help protect our patient, protect our hospital from a financial as well as a risk standpoint, but ultimately it's the patient that we're most focused on. So we need to look at all of those aspects in their entirety. So these were the prevalent pathogens, again, seen by percentage based on the study findings. We saw staph epidermidis, which is a common to our skin surface. And again, if the patient's skin isn't prepped properly, or we're not prepping the entire body of the patient from head to toe. We're normally prepping we're scrubbing basically the area in which the surgical procedure will be taking place, the site of incision. So therefore, you have a lot of areas that are potentially shedding staph epi. The healthcare workers themselves are shedding staph epi. We look at Staphylococcus aureus being 10%. Also a large percentage of the cases, staph pyogenes. Again, all of these other percentages, the 9, 5, 3, and 3%, the prevalent pathogens found in the study, these are all very common to skin contaminants. And again, skin from the healthcare worker and or the patient. So again, these are floating around in the operating room, and if they land on an incision location, incision site, we do then have a subsequent risk of infection. And so the data identified in studies did have, in fact, a correlation of positive airborne samples in instances with high pathogen contamination, especially in the warming system components. So again, that brings to us the fact that we can't disinfect these air warming devices as we thought we could. We can't simply disinfect the surface of that air blanket as we used to think we could. The hosing, the attachment points, we cannot disinfect them appropriately because these devices just have too many nooks and crannies. They have corrugations, they have other folds in the materials that do not allow for appropriate disinfectant penetration, as well as surface dwell time. So that's the key here. In our study, we did not see a correlation with the type of surgical cases that were studied. However, we do know that based on clinical research in general, we know that once we collect more data points, we will see a much higher risk for joint procedures or any other longer, more complex surgeries. So we are currently conducting studies in those various categories at various hospitals, and we're trying to figure out also what are the other risk factors, what other issues are we seeing in operating rooms that can lead to negative patient outcomes. So again, this study, as well as others, concluded that the forced air warming device contamination may be a risk factor in the operating room. And so cross-contamination of the environment becomes an issue as well with the use of such forced air warming devices, and a reduction in surface and airborne CFUs, or the colony-forming units, may positively reduce surgical site and healthcare-associated infections in our patient population. So I hope that everyone has taken away this message in terms of the various devices in the OR, looking at everything in its entirety, but also looking at items that are right in front of our faces. In this case, the surgical site, or in this case, the forced air warming device blankets as a risk factor in causing potential surgical site infection in our patient population. But again, I really do thank everyone for the time that you took out of your busy days to listen to this presentation. And at this point, we can open up for questions from the public.
Thank you very much, Victor. That was a fantastic presentation, and I do appreciate everyone and their patience with our technical difficulties. So as Victor mentioned, we are ready for our question-answer session. We do have a few questions that have come in already, but to remind everyone in the audience, if you would like to ask a question, please use the question function on your webinar dashboard, and we will get to as many questions as we can today. Our first question is, would you please talk a bit more about the CFU levels? Is 10,000 CFU okay?
Correct. That's a very good question. Thank you so much. So we did determine that based on all the literature, the studies, the scientific evidence, anywhere from 10,000 CFU or less, this is sufficient, especially when it comes to the number of, depending on the types of procedures we do. But overall, for, we like to keep it at 10,000 CFUs or less. I know that class 2 surgery, class 2 ratings are for 50,000 CFUs or less, but we like to keep it for sure below 50,000, but closer to 10,000. That's the more desired number, because again, every device increases its risk of transmission, its risk of further contamination in the OR. So again, if you mitigate or remove one risk, you want to make sure that other risks don't increase those CFUs floating around in the room.
Thank you so much. Our next question is, forced air warming is used in most hospital ORs. Does the study indicate that certain pathogens are able to get through the HEPA filter?
Very good question. In terms of HEPA filtration itself, HEPA filters are, for the most part, approximately 99.5% effective in the filtration of air. And again, it has to do with making sure that the filters are maintained properly, that the filters are replaced in accordance to the type of device or the type of filter that has the HEPA filter installed in it. I've known of some facilities that they don't change their HEPA filters, the pre-filters out as often as possible because of either resources, forgetting about them, and so on. So it's all about how effective and efficient your periodic maintenance is on those HEPA filter units, making sure that your air circulation is also maintained through those filters in accordance to the various regulations that govern OR air. We also look at pre-filters. So the HEPA filter is one component of the entire filtration system. We make sure that pre-filters are maintained. Secondarily, we look at the HEPA filters, making sure they're maintained. But for the most part, if you have a highly efficient HEPA filter or an air scrubber, it is beneficial. It will virtually stop everything. However, some viruses may still pass through. So again, the goal is to block or stop the pathway of any type of contamination. So if you have a HEPA filter that just evacuates to the outside of the hospital, well, that's not really going to benefit the OR suite. It's going to benefit the outside. However, if you have a HEPA air filter that's circulating the air in the room, then yes, it is of benefit, and it is of benefit to help capture any of those colony-forming units that may be floating in the environment.
Thank you. That makes a lot of sense. Our next question is, would you be able to track infections that may have developed in these surgeries?
Yes. Actually, every hospital does track infections, especially when it comes to the National Healthcare Surveillance Network, NHSN, through the CDC. It is a requirement that we do track our surgical site infections. But again, how many of the surgeries are being tracked? Depending on the type of surveillance a hospital does, are they actually monitoring every single type of surgery, or are they just monitoring a select type of high-risk surgery only? Also, does the hospital have an effective post-discharge surgical site infection surveillance process? Because again, some hospitals may not have a good process for tracking patients after they leave the hospital. And sometimes if it's an outpatient procedure, or if it's a procedure in which a patient is discharged quickly from the hospital, you might not be able to capture that particular infection unless you're tracking it effectively and efficiently and have a system to do so. So the answer is yes, we can track infections, all infections that may occur as a result of a surgical issue, and try to further deduce, what the cause was. Was it how was the infection seeded? Was it seeded from the air potentially in the room, from a healthcare worker, from a contaminated instrument? We also look to see if it's a type of pathogen that's normal to the environment or normal to the skin cells. Is it a pathogen that requires oxygen to survive, or a pathogen that does not need oxygen to survive? And again, that all boils down to the investigation process of surgical site infection surveillance.
Great. Okay, our next question is, what are your thoughts, given the studies on warming devices, use of PAPRs in the OR with or without surgical mask under the hood?
Okay, so PAPRs, the powered air purifying respirator, these are the devices that are placed on top of the head that seal off basically the individual, the healthcare worker that's wearing the PAPR. When they're exhaling or inhaling, the air is actually being forced up into their around their face through a shield that's sealed, and it is filtered then through the device that's powered, that's attached usually to the top of their head or to their hip. Those particular devices are effective in protecting the healthcare worker. By the healthcare worker, meaning the technician, the nurse, the surgeon, that's what it's there to protect. It's to protect the healthcare worker, but also at the same time, because it's kind of containing the head or face of the healthcare worker, it's also protecting the patient from any shedding cells that may shed from the skin of the face. So in the sense of that particular protection, that does offer protection. From a perspective of wearing a surgical mask beneath that's just an added protection that I think that would be of benefit. But again, it just depends on the model, the type, and the properties of the PAPR. If it's worn properly and disinfected between use on the inside and outside, and it's not taken off or handled during the case, then wearing a mask or not wearing a mask really won't make much of a difference at that point. So the PAPR itself just depends on the type of PAPR that's used, but also to answer the question, the surgical mask may or may not be of benefit. It just might actually be we're not handling the PAPR and taking it off during an OR. So that's where I don't see the benefit of something being applied to the face, since the face is already covered. If that makes sense.
Great. I think it did.
Okay.
Our next question is, are there standards or recommendations for particulate counts in ORs?
That's a really good question. So in ORs, like I said, the particulate counts, or if we look at CFU units of measurement, it is very rare that you'll find an OR that actually measures its particulate counts in the air in the operating room. It's practically, I've never seen it anywhere. Usually these types of studies for air count management, they're conducted if you're trying to figure out how well or efficient the air handling is of the particular room. Because again, based on some of our construction of older construction of the systems that we have in ORs throughout the country, some might not have the exhaust pool or the filtration pool or the air movement that they once had. So in some cases, you'll do smoke tests, you'll do also pressure tests in the room to see negative pressure versus positive pressure, and then you'll also look at the CFUs if you have, for example, an outbreak issue, or you have an issue where you've seen a rise in surgical site infections and you're wondering what the contributing factors are. That's when we usually look at these CFUs that are present in that particular room. And in this case, as I mentioned before, the hospital air contamination limits that the World Health Organization, as well as various other scientific bodies, have determined as being acceptable were, anything 10 CFUs and below being for our high-risk patients, our patients with, like I said, orthopedic, cardiac, transplant, bone marrow, burn unit, high-risk cases. You should have 10 CFUs or less. But again, some facilities get away with having 50 CFUs for their general surgical rooms or corridors, the general OR. Those CFUs can increase with the decreased immunocompromised patients. So again, to answer that question, 10 to 50, 30 should be more of a norm for a regular OR, and 10 or less particulate counts in terms of colony forming units should be the preferred level in the again, the compromised patient population surgical suites.
Great. All right. Here is a question about litigation. It says, all litigation against forced air warming machines were thrown out as being baseless in the evidence that they had contributed to SSIs. Can you comment on that?
Yes, it's all about, again, evidence. Since litigations against forced air warming devices and large companies that produce forced air warming devices, since a lot of these studies had occurred early on, it depends on how a study is performed. It depends on how a study is collected. It depends on how many sites are involved in the study and whether or not the study is actually sponsored by an entity that actually produces, for example, a product that's used in litigation. So there are biases. The studies really, there aren't enough studies published in this arena to discredit the fact that these forced air warming devices do contribute to infection risks. In my opinion, as a professional, as an epidemiologist who's done studies on hundreds of devices, anything, again, from needle-free connectors to Foley catheters to central lines to you name it, anything that's inserted into a patient, around a patient, in a patient's room. I've seen the direct correlations between cross-contamination, the ability to disinfect, and then we look at the OR itself as well. So we look at the air that's being produced or air that's channeling around a patient. And so with that being said, I would never discredit forced air warming devices as being a risk factor. They are a risk factor. They are a risk factor due to the studies that we've conducted and also the ongoing studies that we have being carried out at the moment. They're very demonstrative of risk factors in potentially causing surgical site infections. And so again, you might not have, hundreds of thousands of patients developing infections from forced air warming devices, but you do have enough to substantiate the risk.
Thank you very much for answering those questions, Victor. That was a fantastic presentation, and I would like to encourage everyone in the audience to visit today's sponsor to learn more about the products they provide to our industry. Please visit encompassgroup.com. A quick reminder that you can obtain your certificate by completing today's post-webinar survey. The survey will be emailed out to you 1 hour after the completion of the webinar. You must complete the survey to receive your 1 continuing education hour, and you will be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, please contact us at webinar@mdpublishing.com. We will be back in 2 weeks with another webinar. Please visit ortoday.com/webinars for more details and complimentary registration. Thank you all and have a great day.
Thank you very much.